Good evening, friends. Am I audible to you? Good evening, Captain Krishna. Am I audible to you? Hello, good evening. Am I audible to you? Niharika, good evening. Am I audible to you? Thank you, Niharika. Thank you, Captain Krishna. So, good evening, Vitri Selvan. Thank you. So, shall we begin? Okay, nice. Anything else? For that, do you have any questions to ask? Okay, good evening, Rashid Jain. Good evening, Lavanya. So, shall we begin? Now, this will be the last minute must know MCQs for NEET PG exams, and my purpose is to make sure that if you attend this session, you should be able to go to the exam with some confidence. Either you are a person who has prepared very seriously, or you're just beginning, you have no idea what to do and what not to do in the last 2 days or 3 days. This session should help you go through the whole mile, and I hope this will be helpful for you in cracking the questions. Also remember, I'll be adding a few INICET questions, so this can be very helpful for you in the concept that these questions or the topics from the questions or the topics related to that questions can actually come in your exams. So I'll be giving you parallel topics. I'll be giving you parallel data also, which are highly anticipated in the upcoming NEET exams. So concepts and facts that are running parallel for the upcoming NEET PG exam will be doing it very well. So I hope you'll be able to make use of it. I'm Dr Meenakshi Sundaram A S, MBBS MD and Gold Medalist MD exams, and I'm a high octane educator for biochemistry and microbiology for the past 11 years, and I've successfully placed students in the top institutions. So there is some amount of credibility. You will be able to get the best of the questions here. I'm a prolific quiz master also, and there's a plus subscription here for Unacademy, daily live classes, structured courses, light test quizzes, and unlimited access. Please use code DRASM or DRASM live to get 10% discount, but there is another option coming up. You can have up to 20% discount. Use the code DRASM live. Okay, so these are the Unacademy Lite and batches coming up for you. Crash course and mnemonics and NEET PG previous year question bank. There is also launching of auto daily practice papers. There is also launching of UPSC CMS and MBBS Prof 1. For this also you can take using code DRASM live, and 20% discount can be given. These are the different prices you can see later, and these are the properties of plus iconic subscriptions. Okay, now this was the previous question. Can you tell me what is the answer for this? This was the question raised in INICET 2022 May. And remember, questions, if they are coming out in one particular area, there is a very good chance it can be happening in the remaining areas also. So the answer for this is dengue virus antigen. Please mark my words here. Dengue virus antigen is not actually screened for pathogens when it goes for blood transfusion. And HIV and malaria have been age-old. HBV and HCV have also been taken. Now you have to know, in case of HBV, what exactly are you testing for? It is HBV's HBs antigen. But in case of HCV, you look for the antibody. These are the ones that you have to know slightly more than. Yes, happiness zone. I'll be telling you according to the CDC guidelines also. Please be patient. Now, according to the CDC guidelines, I'll be telling you the answers. Malaria, HIV, HPV, HCV are done, not dengue. But in this area, in the upcoming countries, and also in case of the CDC guidelines, Zika virus has been screened. So look at this part here. We have hepatitis B virus, hepatitis C virus. In case of hepatitis B virus, you go for the HBs antigen and you go for anticore antibody. You also go for nucleic acid amplification test done in case of HBV. And this is done in every donation. From here to here, All of them are done for every donation. In case of bacterial contamination, you do it in case of every platelet donation. Now look for the HIV here. In case of HIV 1 and 2 both are tested. In the previous 2019 exam and 2020 exam, they had asked for the difference between HIV 1 and HIV 2. Remember, HIV 1 and 2, both of them are screened for, but HIV 1 is structurally not related to HIV 2. In fact, HIV 2 is closely related to SIV. This is simian immunodeficiency virus. This was another MCQ. As I tell you a few things, I will try to go parallelly and randomly and ramify into different data. So please don't stick to this particular notion that I'll be telling you the answers only for that question and move forward. When I pick up a statement, whatever the kind of MCQs that have been happened in the past and what are the possible MCQs that are going to come for you in exams, I'll tell you all these things. It is my duty. I feel duty bound to help you in this area. If even one MCQ that what I teach you extra, what I teach you more than what you already know, if that comes in your exam, that my duty is done. So look at this part. In case of HIV 1, these are the questions raised. And in case of HIV 1 and 2, you go for anti-HIV 1 and anti-HIV 2. You also go for nucleic acid amplification test. So right now, NAT has been very effective in making a diagnosis. In case of hepatitis C virus, you go for anti-HCV. Now this was a question in one of the USMLE question papers. Remember, when you're screening for hepatitis B, you go for both HBsAg and anticore antibody. In case of hepatitis C virus, you only go for anti-HCV detection. In case of HIV, you go for anti-HIV 1 and anti-HIV 2 and go for NAT. And you can also screen for HTLV 1 and 2 in case of CDC guidelines. You can go for Treponema pallidum, West Nile virus. See, West Nile virus is actually localized into the American continent, so it can be done. Zika virus has been taken seriously by America, and Babesiosis, Trypanosoma cruzi, cytomegalovirus are also screened in case of USA. If the words are not clear, you can shift the class into the high definition mode, the HD mode, so that you will be able to keep them in the landscape. You will be able to see them, because if I try to zoom, okay, let me try to zoom this. Is it visible here, people? Aishwarya Burkapalle and Happiness Zone, are you able to see this now? Yes. Now look at this. You can also go for HTLV 1 and 2. I'm so sorry, I skipped the things. I'm unable to hold on to this. Sorry about this. Yeah, in case of human immunodeficiency virus 1 and 2, you go for both anti-HV1 and anti-HV2. Here you're not looking for the antigen, but you're looking for the PCR testing. Remember, in case of RNA viruses, generally you run RT-PCR tests. In case of DNA viruses, you run PCR tests. And also, whenever you want to understand the load of a virus, go for example, in case of hepatitis B virus, HBV DNA can tell you the load of the hepatitis B virus infection. You'll also test for HTLV1, Treponema pallidum. West Nile virus is localized for America, so you can think of America. Zika virus can be brought into us also. The Babesia you have. This Babesia is tested in case of CDC guidelines. Trypanosoma cruzi, cytomegalovirus. Trypanosoma cruzi may not be very common in Indian subcontinent where we are going for it, but cytomegalovirus can be tested. All these are to be tested if you go for the exam, especially in case of your blood transfusion. If you have any other questions, you can ask me right now. So let's go for the next question. Which of the following is a molecule? Molecule. Which of the following is a molecule? Yes, when you go for HCV RNA or HBV DNA, you want to look at the load of the viruses. You can also look for the number of virions. Number of virus particles cannot be understood directly, so you go for the DNA or the RNA. Okay, now 1 minute. Okay, so what is the meaning of a molecule? Molly speaks about soft, cute speaks about the skin. It is a Latin derivation of the word. Technically, if I come to this right now, these times of durations, molecule technically means a particular organism who doesn't have a proper cell wall. No proper cell wall. Now, in case of chlamydia and rickettsia, Warrentia is a variant of rickettsia. Rickettsia tsutsugamushi is right now called as Warrentia tsutsugamushi. Remember, rickettsia and chlamydia are obligate intracellular organisms. These are capable of having some kind of wall. These walls may not be exactly like other gram-negative bacteria, but they still have a wall So they will not qualify to be called as molecute. What about chlamydophila? Remember, chlamydophila is a slight variant of chlamydia. People have worked their heads off. They have worked so hard to find out whether chlamydophila or chlamydia related. Yes, of course related. Let me show you this part. According to the authors, now if at all they ask you a question from chlamydophila, I do not want my students to feel like you do not know this. So have a look at this. According to the authors of 1999 study, there is a mean DNA-DNA reassociation difference. Now there are two ways by which you can look for it. One is DNA reassociation. This will be understood as a difference between two organisms, in that the difference was 10.1%. This is an accepted value for genus separation. If the value was more than a particular limit, you can call them as two different genera, chlamydophila and chlamydia. Also, although the 16S ribosomal RNA gene sequencing of 2 are close to 95%, the DNA sequencing using 16S ribosomal RNA has been similar to 95%. So remember, chlamydia is related to chlamydophila. On that basis, chlamydophila also will not be a molecule. Ureaplasma urealyticum is a classical variant of mycoplasma. In mycoplasma, there is a variant called as T strain. T stands for tiny. And this was actually a variant of mycoplasma, right? Remember this MCQ, mycoplasma is the smallest free living bacteria. It is the smallest free living bacteria. While chlamydia and rickettsia, are they smaller than mycoplasma? Yes, they are smaller than mycoplasma, but they are not free-living mycobacteria. I mean, they are not free-living bacteria. That is why I told you they are obligatory intracellular organisms. They are found inside the cells. So if HBsAg positive but HBV DNA undetectable and HBe antigen negative, no need to treat, right? See, HBsAg positive is never a property of going for a treatment. If at all the HBV DNA is undetectable, it means the virus is not available or the virus is not replicating at high level. If HBeAg is negative, the infectious property of the virus is lesser. At this point of time, you may not need to treat, but in regular intervals, you should check for the HBV DNA or look for the symptoms in the patient. Have I answered your question? Happiness zone? Of course, yes, you all know the answers. My point here is to add something more to your answers. So now look at this part. Chlamydia, chlamydophila and rickettsia all are proper cell-containing organisms, even though they are mildly varied. But look at the concepts in case of mycoplasma. So in case of mycoplasma, what are the questions raised? They have asked about wet film mounts. This wet film mount method, whenever something is wet, it gives you lubrication. Lubrication is based on the wetness, the hydration quotient, and also based on the electrolyte content. Now whenever you try to decrease the water, decrease the electrolytes, then that can make any organism immobile. So that brings you the question, wet film mount is to show the motility of the organism. Remember, gliding motility is the motility for mycoplasma. That can be similarly seen in case of ureaplasma. Also remember, this is called as fried egg colonies or poached egg colonies. When they show you this picture, do not confuse mycoplasma with that of ureaplasma. Why ureaplasma is special? Because ureaplasma as an organism is urease positive. Now what are the recent questions raised about urease positivity? The questions raised about urease positivity is that in the order of arrangement, which organisms are urease positive? The most highly dense urease producing organism will be H. pylori, closely followed by Proteus. Then comes your ureaplasma, and you will be having your Staphylococcus aureus. This is the order in which urease production has been noted. And among these organisms, who is capable of causing septicemia? In that, Proteus is capable of causing septicemia, but Staphylococcus aureus is capable of causing septicemia very severely. And if Staphylococcus aureus is causing septicemia, if urease levels are high in the blood, then the urea can be broken down into ammonia. When the ammonia levels are elevated, you can expect metabolic alkalosis. Why am I saying this as a specific information? Because generally any kind of bacterial septicemia will make sure the blood supply to the particular tissue is falling. When the PO2 to a cell is falling, then automatically the cells will shift towards anaerobic glycolysis. And when the cells are shifting towards anaerobic glycolysis, they start producing lactic acid. Lactic acid is a molecular acid which is capable of adding to the anion gap. So you can have high anion gap metabolic acidosis generally in case of septicemia because of a bacteria. Staphylococcus aureus can give you a confusing statement. Whenever the ammonia levels are more than lactic acid, it will be metabolic alkalosis. When lactic acid is more than ammonia, it can be HAGMA, that is high anion gap metabolic acidosis. Question number 1. Next, what is the newer organism they have raised about having urease positivity? The organism is Corynebacterium urea lyticum. This is also a urease positive organism, and this organism is known to attack your urogenital tract. When it releases the ammonia into the urogenital tract, it is capable of causing something called as alkaline encrusted cystitis. It was repeated twice in JIPMA 2020 and INICET 2021. Now look at the important statements here. Ureaplasma is cause of urethritis, point number 1. It may cause bacterial vaginosis. Can you tell me who causes bacterial vaginosis very commonly? Can you tell me which organism causes bacterial vaginosis? Which organism? I'm not asking about vaginitis, I'm asking about vaginosis. Which organism is known for causing vaginosis? Anybody? For any condition, if any kind of recall will be useful, because if the question paper can be shared or if the questions can be understood from different areas, it will be this. Yes, Gardnerella. Remember, Ureaplasma urea-lyticum is a bacteria that is completely out of the league of Gardnerella. Gardnerella was initially referred to as Haemophilus vaginalis. So these two organisms are known for causing vaginosis. Now tell me, can you think of any protozoa who can cause urethritis? This is an MCQ. Protozoa which is known for causing urethritis and later vaginitis. Any protozoa known for causing vaginitis and urethritis? Excellent. The answer will be Trichomonas. So remember, how do you know that this is actually a vaginosis caused by ureaplasma? You can have a characteristic fishy smell. Now, mycoplasma breaches lung barriers. Now they can ask you questions like this. Ureaplasma may not be able to cause systemic infection, but mycoplasma can cause extrapulmonary systemic infection. That can be aseptic meningitis. You can expect erythema multiforme, Stevens-Johnson syndrome in young males. This is related to mycoplasma. So I'm just giving you possible questions that can happen from a related topic. It can cause hemolytic anemia. Can anybody tell me why there is a hemolytic anemia here? Point number 1. You will be able to produce mycoplasma antibodies who have some kind of predilection for the RBC membrane antigen. RBC membrane antigen. If an antibody is produced against mycoplasma, that antibody can attach to the RBC membrane antigen, but that happens at 4 degrees Celsius. This is the basis of cold agglutination test, and this cold agglutination test has been asked twice in the NEET exams and once in the INICET exams in the past 5 years. So cold agglutination test is for mycoplasma, while microscopic agglutination test or macroscopic agglutination test is done in case of Leptospira. Leptospira mat. Now let's move forward. Answer this question. Pseudomonas septicemia causes what? Pseudomonas septicemia can cause what? Remember, all questions are not INICET recalls, so please be with me to learn more. No, the answer is not necrotizing fasciitis. See, remember, Pseudomonas septicemia is very common, especially when the patient is immunosuppressed or he is a very severe burns infections patient. Now, can you tell me a specific immunocompromised state that can make Pseudomonas become deadly? Can you name a specific immunosuppressed state that can make Pseudomonas deadly? A specific immunosuppressed state. No, not Fournier's gangrene. Yes, Niharika, Lavanya, Rachit Jain, you're all saying C. Okay, let's look at that. Tell me, what is a specific immunosuppression state which can cause Pseudomonas septicemia? The answer would be diabetes mellitus, especially type 1. What happens in diabetes mellitus plus that of Pseudomonas infection? It causes something called as ecthyma gangrenosum. It can be a punctate lesion. It can be a punctate necrotizing lesion. The same kind of necrotizing lesion can happen in the ear lobe also. It is malignant otitis externa. Malignant otitis externa. Both can be seen if a patient is having diabetes mellitus as a predisposing factor. Now, what else can they ask you about Pseudomonas? That is the second most common cause of infective endocarditis following intravenous drug abuse. Intravenous drug abuse. Who is the most common cause of infective endocarditis following intravenous drug abuse? Sriram, your answer is understandable. Pseudomonas can become a dangerous organism when it actually is attacking people who are suffering from cystic fibrosis. But the question is about septicemia, the ability of the organism to enter into circulation. So that is why we are going for a predisposing condition. In cystic fibrosis, lung infection can be caused by Pseudomonas. Can anybody tell me one more organism that it has become very important in the last 2 years of questions? Can you name anybody who can speak about one more organism that becomes dangerous in cystic fibrosis lung condition? One is Pseudomonas. If Pseudomonas is not there in the question paper, then you have to think of Burkholderia cepacia. This has become very serious in the last 2 years of question papers. Okay, let's come back to this topic here. Now, if at all you think about the Pseudomonas, it is also capable of causing osteomyelitis. When it is causing osteomyelitis in diabetes mellitus, look at this 3 major condition. Diabetes mellitus, a punctate necrotizing lesion called as ecthyma gangrenosum. It is capable of causing malignant otitis externa. It is the second most common cause of infective endocarditis following drug abuse. The most common cause will be Staphylococcus aureus. I repeat, in case of intravenous drug abuse, the most common cause will be Staphylococcus aureus. So I'll just zoom this picture for you. Have a look at this. Is it okay? Yes, Burkholderia cepacia. Very good. Okay, what else have they asked about Pseudomonas? Pseudomonas is capable of causing green keratitis and green ungual infection, that is nail infection. Nail infections can also be green. The keratitis also can be green, which can be seen by slit examination or even by normal examination. So now comes a question. Many students have made a mistake in the previous year question like this. They have chosen Fournier's gangrene. Fournier's gangrene is a type of anaerobic destruction of the local muscular area. The most common aerobic organisms causing that would be E. coli, Klebsiella, Proteus, which are the 3 major gram-negative enteric bacilli. I repeat, the 3 major gram-negative enteric bacilli capable of causing Fournier's gangrene will be these 3. And you can always count on Staphylococcus and Streptococcus to cause Fournier's gangrene. What about the anaerobic organisms? Bacteroides, Clostridium, Peptostreptococcus. This is not just a microbiology question. This is a general surgery question or surgery with infections question. So make sure you will be able to answer this. Yes, correct. The very good answer, Niharika. It can be sometimes a polymicrobial condition, but choose one among these organisms if at all they ask you in surgery. Now, yes, now there is one more option. They are asked about gangrene, right? They have asked about erythrasma. Who is the causative organism of erythrasma? The causative organism of erythrasma will be, yes, anybody? This erythrasma was asked between 2002 to 2017 5 times. Then it became rarer. Erythrasma is caused by, yes, Corynebacterium minutissimum. Corynebacterium minutissimum. And what are the most important features? You can find apple green refringence, which is a wrong statement. You will be able to see coral red color. You'll be able to see coral red color when you go for visualization of this particular lesion. There was an MCQ that spoke about apple green. Many people jumped into the answer. The answer would be coral red color. Erythrasma, Corynebacterium minutissimum. Then what are the other organisms under Corynebacter that have raised questions? Remember, Corynebacteria Gychium became very important in the previous year 2020 INICET, and that Gychium is known for multi-drug resistance. It is not responding to much of the drugs. And what are diphtheroids? Those organisms who are capable of looking like Corynebacterium diphtheriae. They don't cause a full-blown diphtheria but look like diphtheroids. Now there is one more question. What is diphtherosin? What is diphtherosin? This was asked in the 2017 exam. People did not know how to answer this. Watch very carefully. This is a very important question. Diphtherosin belong to bacteriocin. What are bacteriocins? These are toxins produced by bacteria. Toxins by bacteria against bacteria. They are toxins by bacteria against bacteria so that they can kill the competition. To kill competition and to survive. Now diphtherosin is an example of such kind of toxin. Many people thought they were asking about diphtheria toxin. Diphtheria toxin is different. Diphtherosin is different. Diphtheria toxin attacks eukaryotic cell, and the eukaryotic cell protein translation elongation factor 2 will be inhibited. I repeat, elongation factor 2 is inhibited. Diphtheria toxin inhibits eukaryotic cell. Diphtherosin attacks the other prokaryotic bacteria. Is that clear? Are you finding this type of teaching helpful, or you want me to go only for the NECT questions? You can decide whatever you feel like. Whoever is online, you are the people who are going to drive this class. Whoever is online right now, you will drive this class. So I'll take the class according to what you need. That is what I'm doing. Is it okay if I teach you this way, or you want me to do it in a different way? I'll do it, because this free class is brought to you only for one reason. I want my students, if you're listening to this class, you should be able to do slightly at least better just because you came to my class. That is my only rule. No, can I continue like this, or you want me to do anything else? No, I'm not asking you whether it is helpful. You please give me compliments or something. I'm asking you, can I continue like this to teach you? Yes? Okay. Now there is one more question. Diphtheria toxin attacks eukaryotic cell. Diphtherosin attacks the prokaryotic cell. Now they have asked a question. List the bacteria who are capable of inhibiting protein synthesis. Among the following bacteria, which of the ones are not capable of inhibiting protein synthesis was a question in PJ Chandigarh. Because this is PJ Chandigarh, yes, thank you very much. Because PJ Chandigarh has been brought back into INICET, now you'll be able to have similar questions coming back in NEET also as a sharing part. So I'm not sure whether there is a sharing or not, but there is a very good chance the high yield areas will be understood by any kind of institute. Now, what are the bacteria capable of inhibiting protein synthesis? Now, number one is Pseudomonas. Please take down of this. Pseudomonas exotoxin A. Number 2 is diphtheria toxin, which inhibits elongation factor 2. Next one will be enterohemorrhagic E. coli and enteroinvasive E. coli and Shigella. In all these organisms, you'll be able to have a cytotoxin that is capable of inhibiting 60S ribosome. Then you have one more toxin called as Bordetella pertussis toxin. Bordetella pertussis cytotoxin, that is also capable of inhibiting protein synthesis. Now, one question raised in 2019 JIPMER exam, I believe. What about the Bordetella pertussis? How do you know it is Bordetella? There is one clinical feature in Bordetella that can give you an indication that it is Bordetella. The answer is, if it is a bacterial condition and they are able to find out that there is hypoglycemia, a patient was not diabetic but suddenly he shows symptoms of hypoglycemia, then it is Bordetella. But if at all the patient is hypoglycemic and the infection is a protozoa, what is your understanding? It is malaria. Please take this into account. Look at the glucose levels. SNAR protein inhibition belongs to botulinum toxin and Clostridium tetani. Okay, SNAR protein inhibition is related to clostridial toxins. So in case of hypoglycemia, inform when there is hypoglycemia, and if you know it is a bacterial infection, think of Bordetella. If it is protozoa, think of Plasmodium causing malaria. Okay, now let's move forward. We have discussed enough in this question. What is the causative agent of Favus? Come on, what is the answer here? There is a trend. They have asked question about Kerion. Kerion is a regular component of all exams. The one that is a competition for Kerion in similarity would be Favus. What is the answer for whose organism causing Favus? No, it is not Taenia rubrum. Any other answer? Yes, it can, but it is not known as a primary organism in causing inhibition of protein synthesis. Excellent, Srinija. Srinija Maredi, your answer is right. Sconlani. Lavanya is also correct. Vicky, Niharika, Prathamesh, all of you are correct. The answer is Sconlani. Remember these organisms as very important concepts. Look at this part very clearly. You have TVS. This is tonsurans, violatium and sconlani. These two, TVS, if you're working in a TVS company as a manager or a salesperson, you don't have to stand on the road. You can stand inside or you can sit inside the AC room and you can sell the TVS bikes or cars. I mean bikes. So inside means endo. So endothrix causing organisms are tonsurans, violatium and sconlani. Now you have CAM, CAM. You will not place camera inside the bedroom or a bathroom. They should be outside. They should be outside. CAM. So Canis, Audoni and mentographites. These two organisms will cause hair infection from outside, which is ectothrix. What is thrix? Whenever I speak about thrix, a hair shaft infection has happened. If the organism has penetrated inside, it is endothrix. If the organism is staying outside, it is ectothrix in a hair shaft. Endothrix causing organisms are tonsurans, violatium, sconlani, and the ectothrix causing organisms are Canis, Audoni, and mentographites. This has been asked regularly in many exams, so don't make a mistake. Now look at this part here. Yes, cup-shaped crust, very good. Now look at this part. What is Favus? It's a superficial dermatophyte. The most important keyword is dermatophyte. While if you look at Chirion, Chirion is also superficial infection. And tell me, what is Chirion? Let's finish this and go forward. It is caused by Tinea sconlani and characterized by a scutula. Please look at this part. This is the key word, scutula. As we see Subhatra Gopalakrishnan saying, the cup-shaped crust will be similar to one that of the scutula. In most patients, Favus is a severe form of Tinea capitis. Capitis means the skull and the scalp area will be infected. Now look at this part. You can see the Favus attacking your nails. You can see them attacking here and the whole body, but most commonly attacking your skull. Look at this part. This is how Favus will look. This is how Favus looks. Have a clear look at the picture here. This is how Favus looks. Okay, can you notice the small cup-shaped crusts? These are the scutula in case of Favus. But what is Chirion? Chirion is a soft boggy swelling of the scalp with multiple discharging sinuses. Now let me show you this picture here. Yes, the scrapings of infected skin consists of mycelial threads matted together. Whatever you are seeing here are mycelia. What are mycelia? The fungal colonies will be mycelia. The threads of fungal colony are getting matted. Matting of the fungal colonies is the one that is capable of giving you this part. Yes, boggy swelling is Chirion. Very good. Now they can be oval, nucleated fungal substrate arthroconidia, either free or jointed. You will be able to see arthroconidia. It is sconlani. Now look at this part. This is what is called as Chirion. Chirion is a soft, boggy swelling of the skull with multiple discharging sinuses. Multiple discharging sinuses. And this is different from Favus. What is the core difference between that of Favus and Chirion? You will be having pus from the hair follicles that form the crust or scutula. Okay, pus can come from the hair follicles, which is not seen in case of Favus. Look at the structure of Favus here. In Favus, it was completely a dry area. In Favus, you're able to notice that this is a dry area here. While here it is absolutely moist, you will be able to see the pus coming out of this area, multiple discharging sinus and a soft boggy swelling. Can it occur in adults? Yes, it can happen in adults, but most commonly children can suffer. Children more than adults. Okay. Now what other questions are being raised from this area? Yes, scarring alopecia can be noticed. All these dermatological features you'll be knowing. I'm trying to focus on the microbiological points that can help you in the exams. Yes, now there is one more question. Let me ask you this. See, if you are looking at a Chirion, in case of a skull of a child, there is a soft boggy swelling. I look at it from this side. They show you a picture from the top of the area, and if at all you can notice, the discharging sinuses are coming out from these areas, and the point from which the discharge is coming out, if there is absolutely pitch black, what is the carrion diagnosed as? First level diagnosis carrion. If the discharging sinuses, the opening for discharging sinus is black and mottled, what is the diagnosis? What is the diagnosis? Anybody? If the opening for the discharging sinus are black and mottled, it's called as black dot ringworm. It can come closer to other ringworms also. Here you use the word black dot ringworm. Answer. Now this is an INICET question. Now look for this. See, if it is a trichophyton based kind of organisms, you can always start with a simple kind of antifungal, which is allylamine. As Subhadra Gopalan says, terbinafine can be started. If they don't work, then you can go for higher levels and starting with triazoles like ketoconazole. Look at this part. Which of the following is not a part of the innate immunity? This is a recent INICET question. I have discussed this almost every time when I start an immunology session. This is how we start. B2 lymphocytes is not a part of innate immunity. So I do not remember the other options. My students, I don't think they have given me the other options also. So let me tell you what are the components present in the innate immunity for this sake. The innate immunity can be of 3 or 4 types. One is the physical barrier. For example, the skin by itself is a very tight junction. Epithelia, mucous membrane, mucus itself, all of them are physical barriers. They are also innate immunity. For example, if dust particles and bacteria come and hit on my area, the mucus, which is very sticky, can hold on to the bacteria and throw them out like a phlegm. That is also innate immunity. Next, anatomical barriers. For example, you have phagocytic cell present in certain areas, the lysosome present in the saliva. You know, in childhood, when children fall on the ground, if they have abrasions, they take saliva and put them into the area. It may look like a very dirty practice, but the saliva contains lysozyme and the phagocytes can be actually happening as anatomical barriers. Also remember, the GIT secretions of HCl by itself can be a very important barrier for the organisms entering into the GIT. Now, inflammation related serum proteins like complements, C-reactive protein, lectin, such as mannose-binding lectin, ficolins are all components of innate immunity. Also remember, defensins, cathelicidin, that is phagocyte granule antimicrobial peptides. There is something called as surface phagocyte granule antimicrobial peptide, SPGAMP. This is a part of innate immunity. Also, when you have toll-like receptors, release of cytokines, natural killer cells, mast cells, macrophages are all parts of immune response. And what are the immune response capable of doing innate immunity? They not only prevent infection, they eliminate the invader, they stimulate the acquired immune system. So remember this golden information, this golden concept here. They are not only capable of removing the organism, the innate immunity stimulates the acquired immunity. And always remember, natural killer cell, macrophages, neutrophils are all capable of acting as innate immunity. Now tell me, NK bar T cells will be having a CD3 positivity. Remember, normally simple NK cells have no CD positivity. They are not concerned about CD positivity. But if they are NK bar T cells, they become CD3 plus. Are they acquired or innate? Are they acquired or innate? NK bar T cells, are they acquired or are they acquired immunity or innate immunity? Remember, it's a gray zone between that of innate immunity plus that of acquired immunity coming together. Not always NK cells depend on T. I repeat, NK generally does not depend on T cell. Does not depend on T cell. But T cell support makes NK cells powerful. Makes NK cells powerful. Now, when the T cells are bound to the NK cells, memory cells can be activated. These are the most important points you have to remember. When the NK bar T cells are present, memory cells can be taking their involvement in it. But they are pure NK cells, they don't have any relationship with that of the memory cells. Now look at this question. Interferon gamma release assay measures interferon release against the highly specific TB antigen. Which one? Okay, Captain Abhishek and Niharika. Yes, welcome, Jayachandran. What is your answer? There is something called as quantiferon assay or IGRAS. IGRAS is done for identifying latent tuberculosis. It is done for identifying latent tuberculosis. So, if at all you are going through this pathway, IGRAS means interferon gamma release assay. You are trying to assay the amount of interferon gamma, and they are released against which antigen is my question. What is the answer? Excellent, Vicky A. The right answer is ESAT6. ESAT6, what is it? It is actually an early secreted antigenic target 6 kilodalton protein. I repeat, early secreted antigenic target. It is a 6 kilodalton protein that is produced by Mycobacterium tuberculosis. This question has already become famous since NEET 2018. It happened once to happen in 2019. Now people have not actually having this, but it comes back again. I do not want you to say that you do not know this. I fear my student. So for that reason, I'm telling you, ESAT6 is a highly specific antigen of MTB. It is coming from MTB. It is a secretory protein, point number one. It is not a bound protein, it's a secretory protein, and it is a potent T cell antigen. Generally, if I say something is antigenic, it has to be a protein. Rank number one of antigens is for proteins. Highly immunogenic. Second is the carbohydrates, third will be lipids. So they are proteins, they are highly antigenic. And how will they use them? You will use ESAT6 when you're going for diagnosis of tuberculosis in case of using whole blood. This is also extra information, know it for your sake. Whole blood you're going to test it for. Quantiferon TB Gold is the name of that is the brand name of the test. It is interferon gamma release assay test. Now, if at all they ask you something new in the upcoming question papers, they can ask you ESAT6 is in testing with conjunction with that of what? It can be tested in conjunction with that of CFP10 and TB 7.7. These two antigens may be asked in the upcoming exams. So make sure you remember this. I repeat, you are going for interferon gamma release. Now you are going to measure how much is released, and that is against the ESAT6 antigen. Early secretory antigen. Okay, early secreted antigenic target. And what is 6 meaning? I told you just now. Tell me, what does 6 represent? In ESAT6, what does 6 represent? Anybody please? And this ESAT6 is in conglomeration with that of CFP10 and TB 7.7. Yes, it is 6 kilodaltons. Okay, let's move forward. What is true regarding lepromatous leprosy? Now, this is a question that is similar to the INICET question that we have. We'll discuss it later. Now, just tell me the answer to this question. True regarding lepromatous leprosy is which one? It has less than 3 skin lesions. Lepromin test is positive. It is seen in ENL. Nerve involvement is more pronounced than TT. Which one is the right answer? Yes, okay, so Niharika, Vicky, Captain Krishna, Prathamesh, Rajit Jain are all correct. The answer is ENL. It is seen in ENL. Now, shall I tell you a few things about lepromatous leprosy if you like to? Is okay? No, it is not D, it is C. Can I tell you something about lepromatous leprosy if you'd like to know? See, you might have learned a lot about lepromatous leprosy in STD and skin and other diseases, but if you like to look at a microbiologist perspective, I'll tell you, only if you're interested. Please tell me faster. Okay, now listen to this. In case of lepromatous leprosy, CMI is present or absent? In lepromatous leprosy, CMI is present or absent? Okay, so watch very carefully. CMI is present in both lepromatous leprosy and tuberculous leprosy. This is where the mistake happens. If at all CMI is absent in lepromatous leprosy, does that mean people who are suffering from lepromatous leprosy will have suffering of opportunistic infections like pneumocystis carinii pneumoniae, toxoplasmosis, etc.? No. So CMI is not absent, it is present. Then what is the problem? There is a specific T cell mediated anergy. Anergy means tolerance. Anergy towards lepra bacilli. Towards lepra bacilli. This is the core for understanding the basis of lepromin test. So please understand once again, in lepromatous leprosy, CMI is definitely present, like how it is present in case of tuberculous leprosy also. But CMI is not acting only against lepra bacilli. That is called as specific T cell mediated anergy towards lepra bacilli. So only against lepra bacilli it is failing. So if at all I inject a 0.5 ml of PPD, when the CMI is not involved in attacking the whole bacteria, why will it have interest in attacking the small 0.5 ml of PPD? That is why lepromin test will be negative in case of lepromatous leprosy. While CMI is active against the lepra bacilli in tuberculous leprosy, so lepromin test will be positive in case of tuberculous leprosy. Apart from that, you have to know, in case of lepra reactions, watch very carefully, there is a concept called as lepra reactions. Many MCQs have been raised from this particular topic, so please be very sharp in this. We have type 1 reactions, we have type 2 reactions. Type 2 reactions are referred to as erythema nodosum leprosum, and this happens after 6 months of initiation of ALT, that is anti-lepra therapy. Now type 1 is divided into type 1A and type 1B. Type 1B is referred to as reversal reaction. Type 1A is called as downgrading reaction. Why is this important? When a patient is moving from tuberculous leprosy to borderline tuberculous to borderline lepromatous to lepromatous leprosy, he is slowly becoming worse. Why? Because there is no anti-lepra therapy. If you put the patient on anti-lepra therapy, he starts moving upwards. He gets better. That is when there is ILT. But these reactions are happening within less than 6 months of initiation of anti-lepra therapy. What are the pathology plus, immunology plus, microbiology based questions in this topic? What are the mediators of type 1 reaction, type 2 reaction? Type 2 reaction mediators are TNF alpha. Type 1 mediators are delta and gamma subunits of T cell receptor. Please make a note of this. Delta and gamma subunits of T cell receptor, and ENL happens in lepromatous leprosy. Now there is a question. What about the nerve? The nerve involvement. Neurological involvement is seen in which condition? Neurological involvement is seen in which condition? Is it tuberculous leprosy or lepromatous leprosy? What is your answer? Remember, neurological involvement is present in both. But the difference is, in tuberculous leprosy, you have CMI active against lepra bacilli that is producing a DTH response that is called as a granulomatous response. Now, when there is a granulomatous response, you have a paucibacillary state. The number of bacteria are lesser. Now, if this is a nerve, you have multiple granulomas being formed. The granulomas can cause compressive neuropathy. It is compressive neuropathy. And when the compression of a nerve happens, instantly the results can be seen. That is why when you say more pronounced neurological involvement, the answer is always TT. What happens in lepromatous leprosy? If this is a nerve and the bacilli will be high because you're going for a multibacillary status, then you will be having this bacilli invading the whole nerve multiple times. So this will be invasive neuritis. You will be having invasive neuritis. Among these two, which one is irreversible? Among these two, which one is reversible? Among these two, which one is reversible? When I put the patient on anti-lepra therapy, the granulomas will decrease. When the granulomas decrease, compression can be relieved. But even though if I put the patient on ALT, the ALT will be able to kill the bacteria inside, but the destroyed nerves will not be regained back. So this is generally not reversible. This is reversible. I hope this can happen. Now let's go to the next part. Have a look at this. This is the theory for erythema nodosum leprosum. also known as lepra type 2 reaction, complication of lepromatous leprosy. You will be having inflamed subcutaneous nodules plus fever, lymphadenopathy and arthralgias. Okay, what are the components? Fever, lymphadenopathy, arthralgias, painful subcutaneous nodules, inflamed, accompanied at times. Now look at this. I'm sorry. Now this was INICET recall question. MHC class 1 presents the antigen and activates what? We have told this many times. If at all you have a macrophage, it can act as an antigen presenting cell if it performs three reactions. One is if it captures the antigen, it processes the antigen and presents the antigen or exhibits the antigen. So something comes inside, it is processed and it is brought out as a properly processed antigen. When they bring it out, they come out with the help of MHC class antigens. They'll be using MHC receptors. Now this MHC receptors will be placing the antigens to the T cell receptor. If it is MHC class 1, 1 into 8 is equal to 8. I'm sorry, 2 into 4 is equal to 8. That is called as rule of 8 that comes across the presentation of MHC. So if it is class 1 MHC molecule, it presents it to CD8 lymphocyte. So MHC class 1 presents to CD8 cytotoxic cells. CD4 lymphocyte not into account. Natural killer cells are never concerned about the MHC class 1, and T8 suppressor cells are not involved in the antigen presentation. If at all you think about it, your CD4 cells can activate CD8 suppressor if it wants. It can activate CD8 cytotoxic if it wants. If it wants to chase an organism which is sitting inside the cell, and if it wants to blow the cell back, it wants to bomb blast the cell, then CD8 cytotoxicity will be activated. If it wants to keep the destruction low, it activates CD8 suppressor. But the one who receives the antigen is CD8. Now tell me, who are the ones? CD8, what do you think is the function? CD8 is important for intracellular immunity. It means, can it kill a bacteria? Yes or no? Can it kill a bacteria? Yes or no? CD8 cells, can they kill a bacteria, virus, etc.? Yes or no? CD8 never attacks microbes. It destroys the cell that carries the microbe. That is why they are referred to as cyto. Cell is under destruction, cytotoxicity. So intracellular immunity means they're trying to kill the organisms which are inside by killing the whole cell. It can be intracellular bacteria like atypical bacteria, most of the fungi and all the viruses. Then it can also show anti-tumor action. How? Because they are the most important patral cells. Patral for mutation. Now in case a person has been on, look at this, if somebody has been on solid organ transplantation, the solid organ transplantation, you have to put the patient on immunosuppressants. Why? Because you can have graft versus host rejection or graft versus host disease. Rejection can be stopped if at all you put immunosuppressants. The most commonly used immunosuppressants can be cyclosporin and tacrolimus, which are calcineurin inhibitors. Watch very carefully these important questions. Calcineurin inhibitors will have an effect on NF-kappa B, because of which the T cells are rendered impotent. Why am I saying this? See, T cells are meant to be patrals. They are supposed to chase a mutation and destroy the abnormal cells. But if at all you put the patient on cyclosporin, then the T cells are neutered. They may be present, but they won't be able to kill the mutations. When the mutations accumulate, they are referred to as lymphomas, which can become post-transplantation lymphomas. Okay, next question. Which of the following is not caused by high-risk Hpv strains? This was the, yes, this is the recent INICET question. One small request from everyone. If at all, for some reasons, if you have to leave the class, if you have to leave the class, I request you to just put a thumbs up or a like for the class. please like, share and subscribe to this. If you like and share it, more people can watch the class, more people can actually get helped for the exam. That is good karma paying forward. If you do some good thing for someone, definitely some bigger good things can come back to you. That is the only reason I'm asking you to do that, and that is the purpose of teaching many number of students in a massive way. Okay, tell me, what is the answer for this? Yes, it is laryngeal multiple papillomae. Remember, high risk HPV strains can cause two things. They can cause genital lesions. Look at this. If it is high risk, they can cause invasive malignancies, uterine cervix. The genital lesions are malignant lesions. Now, what are the strains that you have to learn and remember for your exams? This is from INICET. So remember, this has been asked in NEET exams also continuously. HPV strains 1, 2, 3, 4 are caused by, they are known for causing verruca vulgaris, which is called as common warts. They are present in the hands and feet of children and adolescent. Low risk means 6 and 11. There is something called as condyloma acuminatum and intraepithelial neoplasia. See, if it is low risk 6 and 11, it is only up to the level of intraepithelial neoplasia where the tumor cells have not breached the barrier. But once it is 16 and 18, they have breached, they have become malignant, and they can also show metastasis at some point of time. Cervical uterine malignancies, invasive malignancies can be noticed. Once again, 1, 2, 3, 4, hands on the feet of children and adolescent. It is very common warts, absolutely harmless. Low risk can be condyloma acuminatum in the external genitalia. But if it is high risk, it can be invasive malignancies of uterine and cervix. Now, what are the possible cancers caused by HPV? That is also another question. Now, watch very carefully this part. Vaginal cancer, penile cancer, anal cancer, vulvar cancer, cervical cancer, all are understandable. Oropharyngeal squamous cell cancer is caused by HPV high risk strains. Now, this is where many people get confused. Many people have chosen to write EBV as the answer. EBV is known for causing nasopharyngeal carcinoma. EBV is known for causing nasopharyngeal carcinoma, while oropharyngeal squamous cell carcinoma is caused by HPV. Now, some people have asked me, how exactly HPV can cause oropharyngeal? There is a sexual activity, it should be in the genitalia. See, sometimes there can be oral sex, and this has been, HPV has been contributing to 72% of oropharyngeal cancers in USA because of the HPV status. It can attack the base of the tongue, tonsils, soft palate, lateral and posterior pharyngeal walls. EBV is known for causing infectious mononucleosis. Can you name one more virus causing infectious mononucleosis? Can you name one more organism causing infectious mononucleosis? In USA, when they say he caught mono, they are talking about infectious mononucleosis, which is a type of Kissing's disease. Kissing's disease can be an STD or not an STD, where the kissing may be a part of a sexual act or may not be a part of sexual act, but mononucleosis can be caused not only by Epstein-Barr virus, it can be caused by cytomegalovirus also. Now, why is this an important question? When they speak about Paul Bunnell test, it is done in case of infectious mononucleosis, but that is done only if it is caused by Epstein-Barr virus according to the theoretical statements. Is that clear? And remember, it is known for causing nasopharyngeal carcinoma, and because it is going to attack the common B cell marker, it can cause B cell lymphomas. I hope you'll be able to remember this. Now, the student said there was a question related to HPV vaccination. Was there a question related to HPV vaccination? Was it a separate question? Some students said there was a separate question for HPV vaccination schedule also. Is that so? Okay, I'm not very sure whether it was a separate question or not. Look at this part. You can give this HPV vaccination for two different groups of people. Those who are high risk in the earlier stages, or those who are between the 15 to 45 years of age. Now remember, 3-dose series is given for people between 15 to 45 years and is also given for immunocompromised persons. Our first focus will be for children between 9 to 14 years of age who are vulnerable population. In that age group, you go for 2-dose series. The 2-dose series is referred to as 0th month, and then any month between that of 6th month to 12th month. This is one kind of vaccination schedule. The other one is 0, either the first or the second month, and then the 6th month. So 016 or 016 of HPV for people between 15 to 45 years is almost the same schedule for HBV. HBV is also 016. Now what about the HPV vaccines available? Yes, if it is 9 to 14 years or 9 to 12 years, you go for a 2-dose series. Now what are the HPV vaccination details you have to know? There is something called as bivalent vaccine. If it is bivalent, go for 16-18 because they are the highest risk for malignancies. Your first primary concern is to prevent malignancies. If you go for quadrivalent vaccine, you can prevent the genital warts also. So you add 6 and 11. If it is a nonavalent vaccine, that is 9 strains, you add for 6, 11, 16, 18, 31, 33, 45, 52, 58. And what is the dose? 0.5 ml IM. 3 doses between 0 to 16 months. If it is between the years 15 and 45 years. If it is between 9 to 14 years, you go for a 2-dose series. That's all. Hope I have given you the answer. Now, shall we go for, did you see this question? This is a CDBC based question. Did you see this question? Was this question there in the exam? Yes. Now I got information in the Telegram group saying that this was the life cycle shown and the options were given in the form of eggs. Is it true? The options were given. Yes, even though there are too many strains, there is still good. Yes, so based on the egg you have to answer, right? Let me tell you the life cycle here first. Let me make it very faster. See, there are some questions raised. Ankylostoma duodenale is called as old world hookworm. Necator is referred to as new world hookworm. Now what is the life cycle? Human being is the only host. Human is the only host in case of intestinal hookworm. Now this intestinal hookworm enters into the body with the help of a filariform larva. This filariform larva is actually a sharp penetrating agent. It penetrates through the skin and enters into the blood vessels. It is ultimately capable of coming back into the larva. Now remember, Ankylostoma species larvae can become developmentally arrested and dormant in the tissues. In case reactivated larvae may enter into the small intestine from some other area, the larva can become adults inside the human being, and those adults can actually release the eggs and the fecal material. Those eggs can be present in the feces and they can produce a rhabditiform larva. Remember, there were 2 questions about rhabditiform larva in the last 3 years. Rhabditiform larva is not supposed to be a very sharp kind of larva. Filariform larva is the sharper one who is capable of causing invasive properties. And rhabditiform larva is an actively progressive kind of larva. It can move and can start having a lot of eatable activity. Now that can be seen in Strongyloides. Strongyloides stercoralis. So remember, that was an MCQ. Rhabditiform larva is found among which of the following worms? The answer is Strongyloides. It is also found in hookworm. Remember this. Now look at the Ankylostoma duodenale here. If you look at this particular mouth area, you have something called as cutting plates. These are very sharp looking. They are cutting plates. They look like this. But if at all you look at the Ascaris lumbricoides, you will be having lips. The structure will look like this only. But when you see cutting plates here, it is definitely Ankylostoma duodenale. And why is it? Because it is meant for cutting open the mucosal membrane. At the same time, this is also capable of releasing an anticoagulant. Listen very carefully. The Ankylostoma duodenale is capable of releasing an anticoagulant. Yes. It is known to release an anticoagulant. With the help of anticoagulant only, it is capable of releasing the blood continuously. Remember, there was an MCQ 10 years back and that MCQ repeated 5 years back. They said iron deficiency anemia in hookworm is because of hookworm drinking a lot of blood. The answer is no. Hookworm will drink or eat only a very few amount of blood, but the hookworm with the help of cutting plates will be able to create injury. and that injury will bleed, but the bleed will not stop because it has used anticoagulant. So even in the absence of that particular hookworm, bleeding continues. So the loss of blood, iron deficiency anemia, is not because the hookworm drinking, it is because of anticoagulant. That is statement number 1. So remember this. Now look at the eggs. Now this is the picture for the eggs. Look at this part. When I see ankylostoma duodenale eggs, you have to understand it has a pencil thin cortex. This one. The cortex is very thin, and you'll be able to see the clarity between the cortex area and the egg central area. Okay, this egg area and the cortex area, this area I'm sorry, this is very clear. That is the beauty of pencil thin cortex found in ankylostoma duodenale. Now this is the egg of Ascaris lumbricoides. Is it okay if I show you some eggs? I have some 5 slides filled with eggs and picture of eggs. Is it okay if I show the eggs? Dr. Strange, yes, you're welcome for the session. Okay, so how long will you be able to stay in this class? The session is only for helping you, not to make you feel tired. So how long will you be able to stay? How long can you stick with the class? Depending on that, I'll rush the speed. You can decide. If the cortex is extremely corrugated and rough, you think of Ascaris. Now, if it is unfertilized egg, the nuclear content can be anywhere. It can be completely filling the egg. But the moment the fertilization happens, the nucleus gets pulled in. Now you will be able to have a proper demarcation between the cortex and the nucleus. If it is fertilized, you will be able to see demarcation between the cortex and the nucleus. If it is unfertilized, you will not be able to see the demarcation. This is point number 1. Now look at this picture here. What you are seeing here is unfertilized egg. There is no demarcation. Now this is fertilized egg, but the mammillations are present. Let me zoom this for you. Look at this part here. Hello Surendra, thank you very much. Look at this. This area is called as mammillation. So in this picture, you are looking at the egg with mammillations, and this is the cortex. Now the egg nucleus has been secluded. Now there is a proper demarcation. If I try to show you the same area here, there is no demarcation between the cortex and the nucleus. That is called as unfertilized egg. Now you have one more. This is the egg which becomes even more finer to watch. This is mammillated eggs of the Ascaris lumbricoides can be seen now. Absence of mammillations. Okay, this is completely decorticated. Decorticated. I do not want you to get confused here. Now look at this picture here. In this, can you tell me what egg this is? This is biplugged. It is a mucosal plugging on both the ends, and this area, the nucleus, is unsegmented. It is called as unsegmented egg. When the egg is unsegmented and the plugs are bipolar plugged area, this is a classical egg of Trichosis trichura. Excellent, very good. It is Trichosis trichura. Okay, now let me show you another egg here. One minute. Okay, what you are seeing here, this is the egg of Strongyloides. You can see the larva completely bending inside out. You're able to see the larva here. This also will have a very thin kind of cortex. The larva is actually present inside the Strongyloides egg. You'll be able to see them very immensely clearly. Now, what is that you're looking at here? This is the rhabditiform larva. Rhabditiform larva present in case of Strongyloides stercoralis. I'm sorry, rhabditiform larva Strongyloides. Now, what is another important MCQ raised about Strongyloides? Strongyloides is also referred to as the AIDS helminth. The AIDS helminth is Strongyloides stercoralis. AIDS helminth is Strongyloides stercoralis. Now, let's compare the different kinds of eggs together at the same time. We are going to compare the different eggs at the same time. This should be interesting for you. Look at this. What you're seeing here. Can you see the eggs? Is it visible for you? Can you see them? Can you read them? Okay, I'll zoom this for you. See, I'll do that. Be with me. Now, I hope this will be easy for you. We are starting with the ones which can have you this kind of size. This is 0 nanometer, this is 90 nanometers. Can you see Hymnolepis diminuta here? I'll just show you, I'll just tell you how to remember them in a different way, that's all. See, if I try to draw a circle and I draw another circle and another circle, if you can notice, all the circles will have the same center. This is called as concentric circle. It's a concentric circle. But now if I draw a circle here, one circle is bound to one wall, another one is bound to this wall. Now this circle has a center here, this has a center here, this has a center here. You can also have a non-concentric circle. When the eggs are looking like a non-concentric egg, that should make you think about Hymnolepis diminuta. Did you understand this part? See, bile-stained egg will be approximately brown and dull brown, but that is not the way by which you have to differentiate in your exams. In your exams, you will not be able to do it at all. They cannot show you pictures which are very clear for you. So the clarity of the pictures, the color may not be extremely very high definition. The colors, if they are not good enough, you won't be able to do it. So don't trust the colors to make a difference between that of bile-stained and non-bile-stained egg. Remember, if a particular egg is having a chance of traveling through the bile duct and coming into the intestine and coming out of the fecal material, then there is a chance. There is a chance it can be a bile-stained egg. Or you follow this part. For example, Enterobius vermicularis can be present directly in this area without being exposed to the total bile. So it can be a very clear kind of egg. But if you look at this one, these can be bile-stained eggs. Now look at this part. Yes, this is eccentric egg, non-concentric egg. It is Hymnolepis diminuta. Now look at Paragonimus westermanni. Paragonimus westermanni, if you look at it, on the top you have something that looks like a operculum. It looks like an operculum. When they ask you questions about operculum, what are you supposed to answer? See, operculated eggs. What are the most important eggs which are operculated? Operculum is very commonly found in Diphyllobothrium latum. It is also found in Ophisthorchis viverni. You don't have to know this organism, but remember this organism, Clonorchis sinensis. These are the two organisms who are operculum containing egg. Now when you come for Paragonimus westermanni, this is what you are looking at. Okay. Now let me bring you slightly downstairs. Now this is about the size 0 to 90. Can you notice this? The size is 0 to 90. The one which is reaching 90 will be Ascaris lumbricoides infertile egg. Infertile means the cortex and the nucleus differentiation is not there. If they become fertile, they can be differentiated. Paragonimus and Ascaris can have the same size of eggs. Hymnolepis nana can come up to 70 nanometers. Now let me show you eggs which are bigger than them. The schistosoma eggs are so big, they can go up to 150. Schistosoma eggs are so big, they can go up to 150. All these pictures are from Center for Disease Control at Atlanta, USA. Now in this area, look at Japonicum here, Hematobium here, and Mansonae here. You don't have to worry about Mekongii, you don't have to worry about Intercalatum. You have to worry about Japonicum, you have to worry about Hematobium, and you have to worry about Mansonae. Let me give you a small idea about what to see. See, you have spinous eggs. Whenever the egg is having a spine, it has to be schistosoma. schistosome eggs. Now imagine if I draw an egg like this and the spine is at the center. The spine is exactly the center along the axis of the egg. You call it as hematobium egg. Now if at all you look at the egg and the spine is on the corner, then that would be Manzoni eggs. If the corner egg, lateral spine, this is lateral spine, this is central spine, and if the spine is actually having a curved hook-like structure, it is Japonicum. And what are the questions raised about Japonicum? They have asked about Katayama fever. Katayama fever, you have to know it is a property of schistosomes. It can be caused by any of them, but most commonly with Japonicum and Manzoni. Okay, these are the MCQs. So have a look at this. If you look at Manzoni, it is a lateral spine. If it is hematobium, it is a central spine. Japonicum, this is a slightly curved side. Are you okay with this? Now look at equally sized bigger things. These are also flukes. Facialopsis buski is a fluke. Fascia hepatica is also a fluke. Buski is an intestinal fluke, and this was asked in last INICET exam 2021. Facialopsis buski, and this buski was asked in NEET PG 2021 also. So please make a note on this. Facialopsis buski is intestinal. It is intestinal fluke, while Fascia hepatica is a liver fluke. But remember, hematobium is also a fluke. Hematobium, cystoscoma are blood flukes. So when you come for the eggs of flukes, they can reach 150 nanometers, the same as you see here also. Now look at even smaller kinds of eggs. In the smaller eggs, look at Trichosis trichura, not reaching even 16 nanometers, but there are bipolar plugging. Now if you look at Enterobius vermicularis, it looks like a crystal. It looks like a crystal glass, and one end is flattened, the other end is curved. It looks like a lens, and now you'll be able to see the larva bent over inside. Now this is Ascaris lumbricoides fertile. Because it is fertile, you can see the difference between the cortex and the center. Here it is hookworm. Hookworm, remember, it has a very thin, pencil thin cortex, and Diphyllobothrium latum looks like a complete meshwork of it. It looks like a honeycomb area, and the size does not touch 90. Now look at the other eggs also. Look at Hymenopus nana. The difference between Hymenopus nana, yes, the difference between Hymenopus nana and Hymenopus diminuta is H. diminuta had a eccentric egg or a non-concentric egg, while in case of Hymenopus nana, you used to have a concentric egg. Now there was a question. There was a question about Hymenopus nana in your exams. Is it right? There was a question about Hymenopus nana in your question. Yes or no? Yes, we'll see that MCQ in the next question. Now look at Clonorchis sinensis. If I zoom into Clonorchis sinensis, you can look at this part here. This area is the operculum. I told you operculum can be seen in Ophisthorchis viverni. It can be seen in Ophisthorchis viverni. I'm sorry, I don't think you're able to see that. Sorry. Yes, Ophisthorchis viverni, Clonorchis, all these eggs have a operculum. Okay, now let's come back to the egg here. You've seen it. Now look at the question. I think this was the question raised in the exam. We have which of the following is true about the parasite to whom the egg belongs to. This is the egg of Hymenopus, and this Hymenopus egg will be able to show you something here. Can you see this? If you can notice, you will be able to see something here like this. You have hooklets in pairs. You have hooklets in pairs. Is it visible now? Whatever you're seeing here, this is a pair of hooklet, this is a pair of hooklet, this is a pair of hooklet. Let me erase these annotations. These are the hooklets in pairs, and this is Hymelolepis. And if it is Hymelolepis, what are the which is the true statement about the parasite? What is your answer, people? What is your answer? Remember, H. diminuta and H. nana, both of them are tapeworms. They both are tapeworms. If they are tapeworms, they can't look like leaf. Leaf-like is a word meant for trematodes. Trematodes are what? They are flukes. So here these are tapeworms which are cestodes. So option B is wrong. And albendazole is the drug of treatment. The answer is wrong because it is praziquantel. Praziquantel is the drug of choice. Now, eating water-based plants is a source of infection for, again, flukes. Which flukes? You can have Phaseolopsis buski, Phaseola hepatica, can be two conditions. Even sometimes, rarely, Paragonimus westermani also can have eating the water-based plants. And Diphyllobothrium latum also can come closer. But remember the truth, most of the infections are asymptomatic. Option C is the right answer. Most of the infections are asymptomatic. That is the right answer. Now let me show you the life cycle for a minute. Just have a look at the life cycle here. This is the life cycle of Hymelolepis nana and diminuta. See, nana is dwarf tapeworm and diminuta is the rodent tapeworm. Hymelolepis diminuta rat tapeworm, adults measuring 20 to 60 centimeters in length, and you can see them in the rodents and human beings. Now look at this life cycle. A simple word. We start from the letter number 1. Here in the feces, you are able to see the embryonated eggs. The eggs can be ingested by the insect, or the egg is ingested by human beings from contaminated food. The egg goes into the human being. Now, from there, you will be able to have the auto-infection that can happen if the eggs remain in the intestine. Now, from the human being, oncosphere hatches, cystosarcoid develops in the intestinal villus. In case of Hymelolepis and in case of Diphyllobothrium latum, you will be coming across the word cystosarcoid and pleurosarcoid kind of words. Remember, whenever they say cystosarcoid or pleurosarcoid, think about either Hymelolepis or that of your Diphyllobothrium latum. Now it can give rise to scolex. The scolex can become adult in the ileal portion of small intestine. The eggs can be released. In case of a tapeworm, it is not a big deal. Those worms who are capable of sigling and wiggling, if you give praziquantel, it can cause spastic paralysis. When spastic paralysis of a particular worm is needed, so that with one single wash you will be able to defecate the worm easily. But if at all there are certain kind of worms where flaccid paralysis has to happen, then you go for niclosamide. If you are not able to convince them whether it is a tapeworm or a tapeworm or a fluke worm, if it is a nematode, generally for nematodes albendazole can be the drug of choice. Okay. So humans can be infected how? By having pre-cooked cereals, food items, environment, oral exploration of environment with the children, not from the infected plants. Nana and diminuta causes, which are infections which are mostly asymptomatic, and they can cause, if at all, they can cause heavy infections. If they are heavy in nature, they can cause weakness, headaches, anorexia, abdominal pain, diarrhea. Okay, look at these. These are the important points. Praziquantel drug of choice most commonly occurs in children. Only in heavy conditions they can be asymptomatic. Both larval adult forms are seen in the human beings. Okay, this question. Which of the following are acid-fast bacilli? Quicker, people. We are coming to the end of the session. We'll try to finish as much as possible. Come on, which of the following are acid-fast bacilli? When you see the word bacilli, you choose Actinomycetes, Nocardia, and Leprae as bacilli, out of which Actinomycetes is non-acid fast, Nocardia is partially acid fast for 1% sulfuric acid, up to 1% sulfuric acid. M. leprae can resist up to 5% sulfuric acid. Now, did they really mention bacilli? or did they say acid-fast structures? If they had mentioned acid-fast structures, then cyst of isospora, cyst of cyclospora, and cyst of cryptosporidia, they are also acid-fast. They are also acid-fast. Cyst of isospora, cyclospora, cryptosporidium, they are also acid-fast. Remember, head of human sperm is acid-fast. These topics I have discussed almost 10 to 15 times in the last 6 months. So please make sure you remember this for your NEET exams. Head of human sperm is acid-fast, but not the human sperm. Also remember, Legionella, is it acid-fast? Is Legionella acid-fast? Okay, if they did not mention bacilli, the answer is B, C, and D. If they mentioned bacilli, the answer would be B and D only. Actinomyces and nocardia are almost similar. The only way by which you can differentiate between actinomyces and nocardia is by performing acid fasting. Is Legionella acid fast? Remember, Legionella micdadae is acid fast, while Legionella pneumophila is not acid fast. The one who causes Legionnaire's disease is not acid fast. Legionella micdadae is acid fast. One more organism, Rhodococcus, is acid fast. Now let's go to this question. Patient presents with lag of thalmus, orbicularis oculi palsy in left eye, and RAPD. What is the organism? What was your answer? Okay, Vicky says B. Remember, Onchocerca volvulus is not known for causing paralysis. Onchocerca volvulus is known for causing subcutaneous nodules, and if the larval form is attacking the cornea, it can cause keratitis and can cause blindness. This is referred to as river blindness. You can see blindness in case of Onchocerca, but not lag of thalmus, orbicularis oculi palsy, or RAPD. RAPD can speak about Marcus gun pupil. Now, for your understanding, if you have any kind of questions, if you have difficulties in that, okay, they give you Argyll Robertson people as that. Now look at this. You have onchocerciasis or river blindness. This is the Similian black fly. The thing that you are seeing here is the Similian black fly, and these are the organisms seen inside the nodules. Black flies, Similian black flies are the ones who can spread it. The inflammation caused by larvae that die in the eyes results initially in reversible lesions of cornea. When the lesions in the cornea become irreversible, they become blindness. Sometimes they can go to the optic nerve and they can result in vision loss through the optical nerve. They can also attack your peripheral vision and they can eventually cause blindness. But if at all you look at RAPD, the causes of RAPD can be autoimmune disorders like sarcoidosis. I mean, you will be having abnormal conditions like sarcoidosis, autoimmune disorders like systemic lupus erythematosus and Sjogren's syndrome. The infections that can cause RAPD will be cat scratch disease, Bartonella henselae, Treponema pallidum syphilis, Lyme disease. Lyme disease is a very, very common cause of orbicularis oculi muscle paralysis and RAPD. It can also be toxoplasmosis, cytomegalovirus, cryptococcus, TB, etc. Now look at this part. Severe bacterial infections including otitis media, otitis externa, mastocytitis can cause facial nerve palsy. When a facial nerve palsy happens, think of Borrelia burgdorferi. Apart from that, you can think of diphtheria, enterovirus, HIV, varicella, polio, mumps, leprosy. Leprosy is showing its face here. So if at all you had M. leprae bacilli and you don't have any better answer, then you can go for M. leprae. Did you have any other better option? If you don't have any other better option, we'll move forward. Look at this. Now, there was a question regarding this. They said, which of the following viruses have an antigenic shift or drift similar to influenza virus? I don't think we'll be able to answer such a question. You may have influenza virus, RSV, and rotavirus showing some kind of antigenic shift and drift because of genetic reassortment. You can expect genetic reassortment in rotavirus and respiratory syncytial virus. So you can think of these. when it comes to coronavirus and rhinoviruses, there is an existence of many serotypes that allows new infections with related serotypes. That's all. If you want to go for this, this is the answer. Okay. Many serotypes are present in case of coronavirus and rhinovirus and the related serotypes. Now, if at all you want to go for a very badly for an answer, you can think of coronavirus and you can think of Ebola. Now look at this question. A farmer presents with complaints of discomfort in his foot and scrapings were done and the following was seen on microscopy. What is that you're seeing here? These are called as copper penny bodies, also referred to as copper colored sclerotic bodies, and this is found in chromoblastomycosis. Now they have shifted to chromoblastomycosis as a question. I repeat, listen very carefully. Previously they used to have questions based on this part. Let me tell you one thing. Previously, people used to ask questions from Sporotrichosis. The suddenly Sporotrichosis question stopped in NEET 2021. They shifted to chromoblastomycosis. What are the key words you have to know in chromoblastomycosis? The word chromo can speak about the color. You have the copper colored sclerotic bodies. It is caused by copper colored soil saprophytes. Copper colored soil saprophytic fungi. Who are they? The answer would be Cladosporium. They are called as dementitious fungi. Cladosporium, Phyalophora fonseca. And they are also known for causing violet colored wart like lesions. And where do these organisms stay? They actually eat rotten wood or rotting wood. So it means they can eat on the cellulose. Now these copper penny bodies are also seen. Now let's look at this one called as asteroid bodies. Asteroid bodies or cigar shaped globi are a property of asteroid body. Cigar shaped globi are seen in anybody? Asteroid bodies and cigar shaped globi are seen in Sporothrics. Watch this part here. You will be able to notice what is the meaning of the asteroid bodies. They look like this. And the center, you'll be able to see this. The yeast will be like this, and these are the structures. What are they? They're intracellular bodies found inside the macrophages. They have radiating filamentous arms. Radiating filamentous arms is the basis for the asteroid body. And what are the arms? They are arms of myelinoid membranes that contain lipid and are seen within the multinuclear giant cells and are generally believed to be associated with sarcoidosis, but they may also be seen in granulomatous conditions including foreign body granulomas. So remember, asteroid bodies can be seen in sarcoidosis, in case of foreign body granulomas, and also in case of sporotrichosis. Now have a look at this part. This is how sporotrichosis picture can look like. This is how a sporotrichosis picture can look like, and they are lesions along the line of lymphatics on the upper arm. And they have asked you about the treatment for them. Sporotrichosis treatment, cutaneous, lymphocutaneous. If it is a treatment, you go for itraconazole. If the sporotrichosis has attacked the lung and the joints, you go for itraconazole for 12 months. So for cutaneous and lymphocutaneous, it is only for 2 to 4 weeks. If it is disseminated, you can go for liposomal amphotericin B. So remember, these are the most important treatment choices for sporotrichosis. Why am I saying this? Because there was one more question about RK39 antigen being positive. If it was RK39 antigen positive, it is visceral leishmaniasis. There the treatment among the questions was amphotericin B. Here I'm just showing you, in case of sporotrichosis, if it is skin involvement and lymph node involvement, it is itraconazole for 2-4 weeks. If it is pulmonary involvement or joint involvement, it is itraconazole for 12 months. If it is disseminated central nervous in the system, it is going for 4 to 6 weeks of amphotericin B. Now look at this. Which are the following will be the treatment for that person who is sorry, 1 minute. Allah, 20 minutes. 20 minutes. Look at this here. A person tested for RK39 antigen. What is the diagnosis? RK39 antigen should speak about leishmaniasis. If it is leishmaniasis, especially visceral, what is the treatment? Students told me there were only 2 options. One is amphotericin B, the other one is fluconazole. If that is the case, you can go for amphotericin B. But the treatment for visceral leishmaniasis is not restricted to only amphotericin B. Look at this part here. If the RK39 is a rapid immunochromatographic test, they ask you what are the other questions that you can raise from this area. RK39 antigen is an immunochromatographic test and is used widely in the diagnosis of visceral leishmaniasis using serum. Liposomal amphotericin B alone, if it is given as a single dose as a treatment of choice for Kala-Azar elimination program in India. Point number 1. Liposomal amphotericin B in a single dose in combination with 7 days of oral miltefosine or 10 days of paramomycin. That is also another treatment. Miltefosine plus paramomycin can be given for 10 days. Amphotericin B deoxycholate can be given intravenously via infusion. Or miltefosine can be given orally for 28 days or paramomycin intravenously for 28 days. Pentavalent antimonials can also be given intramuscularly or intravenously. They're effective in case of Bangladesh, Nepal, Indian states of Jharkhand, West Bengal and Uttar Pradesh. So what are the possible treatment options you have? Liposomal amphotericin B, miltefosine, and you can also go for paramomycin and pentavalent antimonial drugs. These are very, very important for your understanding. If by some chance the question repeats in a NEET exam, you should not feel like you have never known it. I repeat once again, liposomal amphotericin B, miltefosine, paramomycin, pentavalent antimonials. Let's go for the next question. Fungal cell wall structure containing chitin and beta glucan and galactomannan. Was this the question? Is it right? Is this correct? See, I can tell you this is a very, very, very important question. Very, very, very important question. There is a very good chance it can be repeated because it has been repeated since 2019, 2020, 2021 across the year. In all the 3 NEET exams they have asked you. In all the years, twice when it happened in AIIMS and PJ Chandigarh and JIPMER they have asked you. So they have been a part of at least 17 question papers in the last 3 years. So do not take them lightly. Had they given a diagram? Okay. Now I was ready for this also. Let me show you this picture here. Now look at this. Was this picture shown to you? If this picture was shown to you, it is galactomannan. And if it is galactomannan, there is only one fungus you have to think of. It is Aspergillus species. Why? Because galactomannan is a polysaccharide antigen that exists primarily in the cell wall of Aspergillus only. And galactomannan can be released into the blood only when the Aspergillus was able to cause invasive aspergillosis. When you have invasive aspergillosis, then galactomannan assay can be very useful. Okay. If it is going for aspergillus. No, a color diagram was given. Okay, I do not know which diagram it is, but let me tell you the concepts here. See, this, if at all invasive aspergillosis is seen and the antigen called as galactomannan has released into the circulation, then the presence of this antigen can be measured for 1 to 8 weeks. This is an important point. Please take note. You can see the antigen for 1 to 8 weeks in circulation. Why? Because you just can't clear a fungal infection so faster. So on that basis, 1 to 8 weeks of this antigen can be present. How? Look at this. Mannose beta 14, mannose beta 14, mannose beta 14 repeats n times. Suddenly you introduce galactose alpha 16. I repeat, when you have mannose to mannose beta 14 linkage, and if you bring in suddenly your galactose 1,6 linkage where 22% of galactose is substituted. It is galactomannan. I repeat, mannan is a glucan. The biochemistry behind this is mannan is a glucan. What is a glucan? Glucan means an aldose sugar. Glucan means aldose sugar on repeat mode. That is glucose, 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 or maltose, 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 I'm sorry, glucose, 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 mannose, 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 rhamnose, 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 or galactose, galactose, galactose. If you have an aldose sugar on repeat mode, that is called as glucan. So mannan is a glucan, repeats of mannose sugars here. And suddenly when you can introduce 22% of the substitution done by galactose, then that is called as galactomannan. So remember, galactomannan assay is done for aspergillosis, especially if it is invasive. Done. Now, what are the other things you have to know? Look at this part. One more thing. The aspergillus fumigatus, galactomannan, and the synthetic analogs can be like this. Structural fragments of A. fumigatus, galactomannan. See, A is the structural fragments. Let me zoom this for you. What you are seeing here is the alpha to linkage and fructose fructose linkage of this area. This is galactomannan 1 assay. This is the structural fragments seen. Also, what are the other things you have to notice? Now, they can ask you questions from this area also. Which area? They can ask you questions from beta D glucan assay. Beta D glucan assay. This beta D glucan assay means you're looking for the cell wall components of fungi. Why? Because they're made up of two components called as chitins and glucans, and these are done in case of invasive fungal infections of candidiasis, aspergillosis, and pneumocystis, simply referred to as CAP. And they are not useful in which conditions? They are not useful in mucormycosis and cryptococcosis. This is also an important MCQ. They are not useful in mucormycosis and cryptococcosis. They are useful in candidiasis, aspergillosis, and pneumocystis carinii infection. Now, they can ask you questions like this. This was asked in the previous exam, I believe. False positive assay, that is beta 1 glucan assay or beta D glucan assay, can be seen if the fungal contamination happens. That is, if there are fungal contaminants in antibiotics like amoxicillin clavulanate, piperacillin, tazobactam. If these drugs have fungal contaminants, they can give you false positive answers. False positive can also happen if the bacteria Streptococcus pneumoniae, Pseudomonas aeruginosa, alkylagen faecalis can also be present. Why? Because they also can produce beta D glucan assay. And this is not helpful in mucor or rhizopus and also in case of cryptococcus. So remember them for your exams. Let's move forward. What is the answer for this question? Which of the following is described under Kasowitz law? I got different answers from different students, so I have put up all the options, but the right answer is congenital syphilis. Okay, Kasowitz law is congenital syphilis. What does the law state? If, for example, the mother is infected with syphilis for a longer duration, if the duration is longer, the safer it is for the fetus. Do you understand this? The Kasowitz law is stating that if the mother is infected with syphilis while she is carrying the child, the longer the duration of the syphilis, the better the outcome for the child. Why? Because generally, if there is a shorter duration, you will be able to have stillbirth abortions happening. If the stillbirth and abortion is not happening, it means the child is actually becoming more and more safer. Yes, the child is becoming more and more safer. The protection in your body or the immune system has been working very well. If they were not working well, the child would have actually been attacked and the immune system was just watching, or it was not actually contributing anything. Because of that, the child would have had stillbirth and abortions instantly. So death would have happened. So if the duration has been there, death had happened. If the death had happened for the fetus, the duration of infection has become shortened. Yes or no? Do you understand this? Abhinit Kumar, I'm just telling you this logic. See whether you can understand this. If at all congenital syphilis has caused stillbirth and abortion, death of fetus has happened faster. When that death has happened, you will be able to understand the exposure of the fetus to that particular infection was lesser. But if the child or the fetus has escaped the congenital malformations, then it means the child has been untouched. Kasowitz law is an empirical observation done in congenital syphilis. The law states that greater the duration between the infection of the mother and the conception, the better the outcome for the infant. Features of a better outcome include less chance of stillbirth and of developing congenital syphilis. Okay. Now look at these statements. These are all important for you to know in case they are going to ask you a question similar to this. If a pregnant mother is identified as being infected with syphilis, treatment can effectively prevent congenital syphilis from developing in the fetus, especially if the lady is treated before the 16th week of pregnancy. So if treatment is being given before the 16th week of pregnancy, the amount of duration of treatment also increases. Duration of treatment increases. That can lead to safer outcomes. The fetus is at the greatest risk of contracting syphilis when the mother is in the early stages of infection, but the disease can be passed at any point during pregnancy, even during delivery. The child has not already contracted it. A woman in the secondary stage of syphilis decreases a fetus risk of developing congenital syphilis by 98% if she receives treatment before the last month of pregnancy. Okay, the treatment, if she is receiving it before the last month of pregnancy, the congenital syphilis risk is becoming down lesser and lesser. Okay. An affected child can be treated using antibiotics much like an adult, but however, any kind of changes that have happened will be permanent. Now look at this question. Let me zoom. Yes, a patient complains of an insect crawling, or they say he woke up from the sleep and he says that the insects might have been crawling, or some people are saying spider was crawling all over the chest and the flanks. Chest and the flanks for the past 2 days, and the examination of the patient revealed the given picture. If you can look at them, these are vesicular eruptions. And how are they distributed? They are distributed around a dermatome. So some people got confused. They said spider crawling, all these things might be a psychiatric illness, or it can be a hallucination, tactile hallucination because of cocaine abuse. But none of them was an option, right? So you don't have to worry about it. These all are vesicular eruptions along the dermatome, and they are zoster. This is herpes zoster. If herpes zoster is a reactivation from the ganglion, what is the primary infection? Yes, they are grouped vesicles. If herpes zoster is the reactivation, what is the primary infection? The primary infection is varicella. Okay. Now this, can you tell me what is this a picture of? What are you looking at here? What is this? This is not varicella. You're looking at pearl-like eruptions with central plugging. This central plugging. This is a case of excellent, Captain Krishna. This is a case of Molluscum contagiosum. Okay, let's go for the next. This is a type of DNA viral infection, which is Molluscum contagiosum virus. What is the key information here? Molluscum contagiosum can be spread through droplets also. It can be spread by sexual transmission also, but it is the most common DNA viral pox infections. Most common DNA viral pox infections. Okay, now look at this part. Among the pox infections, not DNA viral, I'm sorry. The most common pox infection is not DNA viral infection. The most common pox infection is Molluscum contagiosum. Okay, now look at this question. This is an interesting question, I believe. I'm so sorry. When a patient complains of perrectal bleeding with eczematous lesions and he has thrombocytopenia, with this question itself you can actually have an idea. It is Wiskott-Aldrich syndrome. Why? Because in Wiskott-Aldrich syndrome you have a triad. What is a triad? You look for eczema. The next one is decreased platelet count and size. Also you expect recurrent infections plus diarrhea. With that, you are seeing perrectal bleeding. Perrectal bleeding is an attribution of which part of the triad? The perrectal bleeding that you are seeing here is an attribution for which part of the triad? Yes, decreased platelet. Now they're asking you what is the next investigations you will run through it. The next investigation I have to go for is WASP gene study. I don't have to look for Ig levels. I don't have to go for platelet study under the microscope. Platelet under the study in the microscope is not going to show you much of a difference. It can, yes, it is not idiopathic thrombocytopenic purpura because they did not say that it was actually following an infection. Did they say it was following an infection? Did they say it followed an infection? Yes or no? If it follows an infection, it is no more idiopathic thrombocytopenic purpura. Okay, this is Wiskott-Aldrich syndrome. What are the most important pointers towards Wiskott-Aldrich syndrome apart from the triad? I told you about the triad, right? That is eczema, continuous itching, and you have decreased platelet count, and you have recurrent infections or diarrhea. The other features, you can have small defective platelets and shortened T-half. Mutations in the WASP gene can confirm it is Wiskott-Aldrich syndrome. Is an X-linked disorder. Now, whenever the patient when will you notice it? When the child has gone for a circumcision, from the site there is continuous bleeding, or there is bloody diarrhea during infancy, or IgM levels are low. IgG, IgA are normal. Ig levels are frequently elevated, but they will not be able to tell you that the diagnosis is Wiskott-Aldrich syndrome, because even in case of hyper IgM syndrome, you will be able to have the Ig levels elevated. And remember, you will be having a disorder of phagocytosis of a macrophage, and these patients are more prone for B-cell lymphomas. Next question. Most common presentation of pot spine. I don't know whether it is a microbiology question or orthopedics question. If it's an orthopedics question, I can only tell you that this is a clear case of paradiscal involvement. The most common presentation of Pott's spine is paradiscal involvement, and these are the features of Pott's disease. Pott's disease can happen only when the MTB has become extrapulmonary. That is, there is a hematogenous spread. From the hematogenous spread of the lungs, it has actually gone. The lower thoracic, upper lumbar vertebrae areas of the spine are more commonly affected. They ask you, the lower thoracic and the upper lumbar vertebrae are most commonly affected. It is a kind of tuberculosis arthritis of the intervertebral joints. And the infection can spread from two adjacent vertebrae into the adjoining intervertebral disc space. If only one vertebra is affected, the disc is normal. Please remember, if only one vertebra is affected, the disc is normal. If it is attacking the two adjacent vertebrae, then the disc may be affected. If the two are involved, the disc, which is avascular, cannot receive nutrients. So you can have avascular activity if the two of them are involved. The spread of infection from the lumbar vertebrae to the psoas muscle causes abscesses. It is not uncommon, and it is named after Percival's pot. Vertebral collapse resulting in kyphosis, spinal cord compression, sinus formation are the features of Pott's spine. Okay, paradiscal lesion. The narrowing of disc space, early radiological finding. The narrowing of the disc space is the early radiological finding. Narrowing of the space may be due to atrophy of the disc tissue or prolapse of the disc. Two important features. You can take them down if you like. Both sides of the disc are involved. Narrowing of the disc will be the earliest radiological finding. Narrowing of the disc can be because of either the atrophy of the disc tissue or prolapse of the disc tissue. Now, what is the answer to this question? The marker for natural killer cell is we are coming closer. Come on, people. The marker for the natural killer cells is which one? See, when you have CD4 cells, we divide them into effector helper cells and regulatory helper cells. The effector helper cells are CD25 negative. CD25 positive will be regulatory. You can also call them as T-reg cells. CD3 is a marker of what? Okay, so Captain Krishna, Vicky, Lavanya, both of them are okay. Captain Krishna and Lavanya saying A, Vicky saying B. Now, let me tell you this. See, CD94, also referred to as NKG2, is a family of C-type lectin receptor which are expressed predominantly on the surface of NK cells and a subset of CD8 T lymphocyte. I repeat, CD94 by NKG2. CD94 NKG2. This is the marker for natural killer cells. They are present on natural killer cells and also on a subset of T8 lymphocytes. Next, in contrast to NK bar T cells, NK cells do not express T cell antigen receptors or pan T cell marker. When I say NK cells, they don't have CD cell CD4 markers, they don't have CD3 receptor antigens, they don't have surface immunoglobulins, but they usually express the surface markers called as, if at all you look for pure NK cells, what you have is CD16, FC gamma or III or CD57. These are the markers that you see in case of NK in normal activity. These are NKG2, that is why CD94. Because there is no CD16 or CD57, I choose CD94. What about CD3? CD3 is a pan T cell marker. What about CD68, anybody? CD68 is highly expressed by the cells in monocyte lineage and osteoclasts, and you can look for them in LAMP family. CD68 localizes primarily to the lysosome and endosomes. Just remember, CD68 localized to lysosomes and endosomes. I'm showing you this because these are options. If they pick up a question from one of these options, you should not feel like you do not know it. CD68 are highly expressed by the cells in the monocyte lineage of osteoclasts. What are the extra points? They are functionally and evolutionarily related to the other gene protein family members as follows: the hematopoietic mucin-like family of molecules that includes leukocyalin, which is also CD43. Stem cell antigen is CD34. 43, 34. Okay, let's go to the next question. Which of the following is not? Sorry. Which of the following is not an age-defining illness? Which of the following is not an age-defining illness? Answers? See, the answer is melanoma. That is not an age-defining illness. Melanoma is not an age-defining illness. All the others can be taken as age-defining illness. That brings us the question: what are the different kinds of age-defining illness? Let me tell you this here. Multiple recurrent bacterial infections. If there is candidiasis of esophagus, bronchi, trachea, lungs, because these areas are generally not known for candidiasis. If you find esophageal candidiasis or bronchial candidiasis, tracheal candidiasis, lung candidiasis, you can think of AIDS. Cervical cancer, if it is invasive, it can be age-defining. Coccidioidomycosis, if it is disseminated or extrapulmonary. Cryptococcosis, extrapulmonary, because Cryptococcus most commonly causes pneumonia even in non-AIDS patients, immunocompetent people. Cryptosporidiosis, chronic intestinal more than 1 month. Cryptosporidiosis, Cyclospora for more than 1 month, chronic intestinal, it is age-defining. Cytomegalovirus other than liver, spleen, nodes, and the onset at the age more than 1 month. Cytomegalovirus retinitis with the loss of vision. Encephalopathy, HIV-related encephalopathy can be age-defining. Herpes simplex, chronic ulcers of more than 1 month duration, bronchitis, pneumonitis, esophagitis, and onset at more than 1 month duration, all of them are age-defining illness. What else? If histoplasmosis is disseminated, that is age-defining. Isosporiasis, chronic intestinal more than 1 month, it is age-defining. Kaposi sarcoma, definitely age-defining. Lymphoid interstitial pneumonia, pulmonary lymphoid hyperplasia complex, Burkitt's lymphoma, immunoblastic lymphoma, primary brain lymphoma. Then you will be having Mycobacterium avium complex, Kansasi, which is disseminated, tuberculosis of any site, pulmonary, disseminated, extrapulmonary, etc. Mycobacterium, other species or unidentified species, extrapulmonary pneumocystis cerevisiae pneumonia, extrapulmonary tuberculosis, extrapulmonary mycobacterial infection, pneumocystis cerevisiae pneumonia, recurrent pneumonia, progressive multifocal leukoencephalopathy, a chronic viral disease, Salmonella septicemia, which is recurrent, toxoplasmosis of brain, in a brain tissue when there is a random areas of calcification, and if you can find it as toxoplasma, that defines AIDS. Wasting syndrome attributed to HIV, all these are AIDS defining illness. The one that is not an AIDS defining illness is melanoma. What is the normal ratio of B cells and T cells? Remember, if B cells are 1, the T cells should be 3 or T cells should be 4. So the answer can be 1:4 or 1:3. But if B cells are actually 20% and T cells are actually 80%, then that will be 1:4. The answer is 1:4. If they had asked the question like this, if it is T cell is to B cell, then the answer is 4:1. If there is no 4:1, then the answer can be 3:1. If it is B cell is to T cell, then it is 1:4. If there is no 1:4, then the answer is 1:3. I have given you all possible ways by which the answer can be shown. Lymphocytes in human circulating blood are approximately 80 to 90% T cells and 10 to 20% B cells. That's all. Last two questions. Which of the following is not a cost-effective investigation done as a part of screening test for a pregnant female? Was this question present? Did you have this question in the exam? Is it the same question? See, if you're looking for cost effectiveness, VDRL is very cost effective, HIV is cost effective, HBEV is cost effective. All these are screening tests done in case of a pregnant female. But echocardiogram is not a cost effective one. It may be done, and echocardiogram can be done if there is a cardiac situation in the female. If there is a cardiac situation only, you will be performing echocardiogram. But for normal screening test, echocardiogram cannot be a cost-effective one. Only when they say there is a cardiac situation, you can think of it. Okay. Now look at this question. A male patient presenting with thickened peripheral nerve and an anesthetic or hypoaesthetic patch. Thickened peripheral nerve, anesthetic or hypoaesthetic patch, satellite lesion. It most commonly speaks about a paucibacillary state. If they say multiple lesions are present, then it can be a multibacillary state. Remember, if at all you look at leprosy here, you are right now going for multi-drug therapy, and multi-drug therapy for 6 months would be the best answer at this point of time. Okay. Going for a monodrug therapy is not a very ideal activity because single drug therapy can encourage drug resistance. This can encourage drug resistance. For that reason, go for multi-drug treatment. And if it is a paucibacillary state, go for just 6 months. Okay. And the last question for the day: in pregnant females showing type 2 lepra reactions, what is the ideal next step in the management? If there is a type 2 lepra reaction, remember there are multiple bacilli present and the patient has been put on more than 6 months of anti-lepra therapy, in which rifampicin has played a very important role. Rifampicin starts breaking down the bacilli rapid fast. When a bacillus is broken, the internal antigens are leaked, against which local inflammation happens and TNF alpha is activated, because of which you have there is erythema nodosum leprosum. At that point of time, you should not stop the ALT, but you have to start the patient on steroids and continue the MDT, multi-drug therapy, and you have to just add steroids. And if steroids are not only helpful, if along with the steroids you can go for antipyretic agents. Remember, thalidomide is not contraindicated in type 2 lepra reaction, but it is contraindicated in type 1 lepra reactions. Okay. Here we will not be choosing thalidomide when the option B is present. You continue the multi-drug therapy and add the steroids. That is the best answer if there is a type 2 lepra reactions going on. I don't have the pictures of them, and also a pharmacologist would be able to explain it better for you. Just remember, multi-drug therapy 6 months. Multi-drug therapy for 12 months can be for the other part of leprosy. So, is there any other doubts that you have? So, let me tell you one thing. If you're going for the NEET PG exams, you have to understand you have done whatever you can do. you have made your best efforts at this point of time. Remember one thing, do not feel guilty for things which you cannot do. You can only do what you can. That is the global, universal, logical statement. You can do only what you can do. Give your best. If you can't, it is okay. Don't feel guilty. But right now, your choice should be to make sure that every single minute is spent very preciously. And if you go to the exam, you don't have to put everything under stress. Please think about all the stress to be a hindrance for you. So only when you actually ignore all these thought process, you will be able to do it. Ignore those thought process authoritatively. You have the rights to ignore the thought process. Many times you are feeling guilty because you think it is your duty to feel guilty. Many times you are feeling guilty because you think it is your duty to feel guilty. But now feeling guilty, feeling remorseful, feeling about the things that you have lost time on these things, all these things are not going to help you in the exams. They are going to stop you from getting a good rank. So you have the right, you have the liberty to forget about all the thought process, focus only on your studies. When you focus on your studies right now in the next period, it is okay. Sleep at least for 6 to 7 hours or 8 hours for the day before exam. Drink very light kind of juices. Eat very light kind of food in the morning when you go for your exams. Whenever the exams are, eat lightly. And that is capable of giving you enough amount of glucose to go through the power through the examination hall. On the day of exam, those 3.5 hours are very important for you rather than these 3 days. Okay, in these 3 days, whatever you read will not be able to reflect on the whole procedure of 19 subjects. In the 3 days, you will not be able to cover all the 19 subjects. You can revise them effectively, understandable in the most important area. But those 3.5 hours will be more important than the 3 days. So sleep very well. Do not actually lose your sleep for the exam, because when you lose your sleep for the exam, your brain will not be giving you optimal function. If you are performing at the range of 90th percentile, if you sleep very badly, you may perform at the 75th percentile of your activity. So sleep well before you go for your exams. If the question said type 1 reaction, would the answer be the same? If it is type 1 reaction also, the only thing you have to do is please continue multi-drug therapy and use steroids. And steroids and antipyretics can be used. You can first go for antipyretics and then go for steroids. Okay. What about the differentiation of fungus based on morphology? Yes, we'll do it very faster. Fungi, you divide them into yeast, mold, yeast-like fungi, dimorphic fungi. Yeast are just spherical structures of the nucleus. Example, Cryptococcus. Molds are filamentous organisms. Example, all the soil saprophytes including Trichophyton. Yeast-like fungus will be Candida on one side and Penicillium on the other side. And Candida will be having a pseudohyphae, while Penicillium marnafi will not be having a pseudohyphae. And dimorphic fungi can be Histoplasma, Blastomyces, Coccidioides, Paracoccidioides, and Sporothex. And these two organisms are known for exhibiting dimorphism. When they say somebody is exhibiting dimorphism, you can think of yeast-like fungi and dimorphic fungi, and they are known for causing systemic mycosis, out of which these organisms are known to cause endemic mycosis because they are localized to certain area. This is the classification of fungi. I have given you examples also. So I hope this helps you in your exams. All the very best for your exams. From the bottom of my heart, I wish the best for you. Do well. If possible, before the exams on one day, 19th or 20th, I'll try to do an Unacademy app session for another 30 more MCQs if you are in a good mood to listen to them. Till then, thank you very much, and please put a like on this video and share this video so that it can be helping more people. The number of good things we do, good things will come back to us. Okay, all the very best. Have a good day. Bye bye.